Hi, everybody. This is Phil Kantoff at Convergent Therapeutics. As many of you know, I left the Dana-Farber Cancer Institute after being there for 28 years in 2015 to become the chair of medicine at Memorial Sloan Kettering, and was there for 6 years, and then returned to Boston 2 years ago to be the first employee at this company, Convergent Therapeutics, which is a radio antibody company. So the basis of what we're trying to do is create radio antibodies, and our first asset is a radio antibody targeting prostate-specific membrane antigen PSMA. And the backbone of this therapy is an antibody that Neil Bander had discovered some 20 years ago called J591, which we now know as Convo-1, and it has some interesting characteristics. First of all, it has a very high binding affinity and avidity for its target, which is PSMA. It has a very short half-life for an antibody, as opposed to therapeutic antibodies whose half-lives are in weeks. The half-life of Convo-1 is 2 to 3 days. And the majority of the reason for the short half-life is the fact that we use a very small quantity of antibody. It's not a therapeutic antibody, but rather a carrier. Another interesting characteristic is that it binds to the PSMA molecule in a different location than where the radioligands bind, the radioligands being Pluvicto, for example, which bind to the active site of PSMA, and Convo-1 binds to a different region, the apical region in PSMA, and there's no salivary or lacrimal gland binding. So there's a cartoon over here showing the antibody, previously known as J591, now Convo-1, coupled to a chelate, which is DOTA, D-O-T-A, and DOTA acts as a cage for the actinium radionuclide, which is what we use in combination with Convo-1, and the acid is known as Convo-1 alpha. Another important feature of what we're working with is we're working with an alpha-emitting radionuclide known as actinium-225, in distinction to the beta-emitting radionuclides such as lutetium-177, which is part of Pluvicto and some other radioligands that are being tested out there. So alphas are helium nuclei and therefore are much bigger than betas, which are electrons. The path length is much shorter than beta-emitting radionuclides, and the energy that's imparted by an alpha particle is much greater than a beta particle, maybe 500 times as strong. And alphas cause double-strand breaks in DNA as opposed to single-strand breaks, and double-strand breaks are much more difficult to repair. An important distinction is the distinction between using antibodies or large molecules and using small molecules or ligands. The ligands that are commonly used are shown on the right. PSMA-617 is the ligand that's attached to lutetium-177 in Pluvicto, and INT is being used by Point and Curium as the backbone for their lutetium conjugates. So in distinction to ligands, antibodies have a greater affinity and avidity for PSMA. The short half-life that I mentioned before leads to increased tumor exposure and uptake by the cancer cell. It's much better in getting internalized and retained by the cancer cell than are ligands. And antibodies obviously can be used to treat multiple tumor types and can be engineered to enable tuning of the PK and excretory routes. This is the biodistribution of radioligands targeting PSMA as opposed to radioantibodies. The important things to note here are that the mode of excretion of radioligands is through the kidneys, and there's substantial salivary gland and lacrimal gland uptake. Now, with Pluvicto, there is not much mention of significant toxicity to the salivary gland or lacrimal glands, and not much mention of renal toxicity. That's using a beta-emitting radionuclide as opposed to an alpha, where the concern for greater lacrimal gland and salivary gland toxicity is there, and the potential for renal toxicity is also substantial. The radioantibody antibodies are excreted through the hepatobiliary system, and there's no significant uptake in the salivary glands or lacrimal gland. So one of the issues surrounding the administration of an actinium-labeled small molecule ligand like PSMA 617, the backbone of Pluvicto, is the toxicity, particularly to the salivary glands and lacrimal glands. So this is a paper that was published several months ago in a nuclear medicine journal, and it took a number of patients that were treated with actinium 225-617, a retrospective take on the toxicity associated with the treatment. And the commonest toxicity is grade 1 to 2 dry mouth. Xerostomia was seen in 94% of patients. In the discussion, the authors say that there's no reversibility and that patients tend to adjust to the new lifestyle of living with xerostomia by using over-the-counter saliva substitutes and drinking water frequently. So this is a substantial amount of toxicity for patients with advanced cancer. Now, moving over to the clinical data, this is the first experiment that was done. The lead was Scott Tagawa at Cornell. And this was the first experiment looking at a single dose of Convo-1 alpha in patients who have been previously heavily treated for their prostate cancers. These patients received prior androgen deprivation therapy, second and third line hormonal therapy. Many got chemotherapy, about 2/3 got chemotherapy or refused or were considered unfit for chemotherapy. Almost half the patients received radioligand therapy, lutetium-177 radioligand therapy. 28% of patients received radium-223. So on the left is the PSA waterfall plot after giving one dose of Convo-1 alpha. These are the doses that were given. All these patients had undergone a PSMA PET scan at baseline, but nobody was excluded based on uptake, in distinction to some of the other studies that have been done, either the VISION study or the study conducted in Australia, where patients were not entered into the study because of low avidity for PSMA, or in addition, having a positive FDG PET scan. So these are relatively unselected patients who came into Cornell with far advanced prostate cancer. And you can see 45% of patients had a PSA decline of greater than 50%. And patients who have been treated with Pluvicto responded just as well to those who had not been treated with prior Pluvicto. And this is not surprising given the fact that we're dealing with an alpha-emitting radionuclide, actinium-225, as opposed to a beta, lutetium, and also the fact that antibodies have a greater uptake and retention into the cancer cell. I should mention that no MTD was reached in this study. There were 12 cases of grade 1 xerostomia. Most of those patients had received prior radioligand therapy, and the xerostomia was reversible. The second experiment that was done was a multi-dose experiment, and I'm going to take you through a cohort of patients that were treated with 2 doses of Convo-1 alpha 2 weeks apart. So just 2 doses, 2 weeks apart. Once again, these were far advanced patients, heavily pre-treated, including prior chemotherapy, prior ARSIs, immunotherapy, radionuclide therapy, etc. These are the 4 cohorts that were looked at, either a dose of 45 kilobecquerels per kilograms times 2, 55 times 2, 60 times 2, or 65 times 2. The asterisks denote prior radionuclide therapy, which could have been Pluvicto, radium, or lutetium J591 therapy. What you can see here is the majority of patients had PSA declines of greater than 50%, 71% of them, and 29% of patients had a decline in PSA of greater than 90%. Thrombocytopenia at the highest dose cohort was seen, grade 3 and grade 4. And that is the dose-limiting toxicity. These are the duration of response, the swimmer's plots. For the whole cohort, the median time to PSA progression was 5 months. And for cohort 3, the highest dose cohort, it was 8.1 months, which really looks very impressive. And as many of you know, the time to PSA failure will predate the time to radiographic failure by months and sometimes years. This is another experiment that was done and presented at GU ASCO this year. This was an attempt at sensitizing tumors to pembrolizumab with Convo-1 alpha. So patients were treated with every 6-week pembro plus a second or third line ARSI and 1 dose of Convo-1 alpha. Once again, these are pretty heavily pretreated patients, although the distinction here is no patients got chemotherapy for CRPC. There was 1 patient that got chemotherapy in the hormone-sensitive setting. These are the fairly typical PSA waterfall plots that we're seeing with Convo-1 alpha. Once again, this is 1 dose of Convo-1 alpha, but the 2 dose levels that we use were 65 and 80 kilobecquerels in cohort 1 and cohort 2, which is lower than the doses that were achieved in the single dose experiment. But nonetheless, we did see these waterfall plots at the single dose in combination with pembro and a second or third line ARSI. But the impressive thing that we found in this study was that the responses of some of the patients in the higher dose cohort were pretty durable. And these 3 patients at the bottom here remain in remission at the present time over 2015 and 16 months. Whether this is due to sensitization to pembro or alternatively the fact that we're treating patients with earlier disease, that is prior to chemo, we don't know at this point, but we're exploring both possibilities. And the final clinical experiment that I want to show you is combining Convo-1 alpha with lutetium PSMA INT, the radioligand using lutetium. And the basis for doing this combination is work that was done by Neil Bander, demonstrating that antibody increases the uptake and retention of the radioligand. In addition, there are advantages to using alphas as opposed to betas, and there are different biodistributions, as I showed you before, between the radioligand and the radioantibody. These are patients who also underwent a PSMA PET scan at baseline, and this is the phase 1 portion of the study. This is the prior treatment of these patients, heavily pre-treated, as you can see, similar to the other studies that I showed you. And here's the PSA waterfall plot that was seen. Note that the doses given of Convo-1 alpha were about half of the doses that were given in the previous studies when multiple doses were given, particularly in the multi-ascending dose trial. This is about half the dose of that. And the dose of PSMA INT was about half of the total dose that was given in the studies that have used lutetium PSMA INT. So this is low dose therapy, very well tolerated. Most of the patients had PSA declines, and there's some durable responses seen here as well. Here's the conversion of CTCs after treatment. So very promising combination trial. So in conclusion, antibodies provide an excellent therapeutic window for the delivery of actinium-225 in PSMA-directed therapy. There's an opportunity to expand into other PSMA-positive diseases in other solid tumors. About 2/3 of other solid tumors express PSMA in the microvasculature of the tumor. And finally, Convergent is committed to developing radioantibodies to other cancer surface antigens. So I will stop right there and thank you all for your time.